So today we're answering a user question on when we use an A-lift versus a T-lift versus a lateral interbody fusion. So it's actually a very good question. It's a question that we deal with daily in our clinic. So before I start, I want to preface this by a little anecdote I had. I was at a spine meeting, international meeting a few years ago, and we were looking at some case studies. It was myself, it was a surgeon from Asia, and a surgeon from Australia. And we were looking at a patient, and they were asking us, how would you approach it? And the Australian guy said he would do an A-lift. I said I would do a T-lift. The guy from Korea said he would do a lateral. So this particular patient, the anatomy was great, that you could do it through any approach, and 3 experienced surgeons all had different approaches, but they all felt that they'd be able to get a good outcome because they do it a lot. So a lot of it does boil down to the surgeon comfort and what they're used to and what their experience is with these types of techniques. The anterior approach, the major advantage is you get a very direct exposure to the disc space, allows you to put a bigger disc implant in, and allows you to open the disc space a little bit more. The downsides of the approach, you are going through the abdominal cavity. There are major vessels there that can get injured. A lot of times you need a second surgeon, what's called an access surgeon, to help you get there, although some people do this without an access surgeon. In males, particularly in males of childbearing age, there is potentially a risk of injury to some of the nerves that travel down to sexual function, and that can result in a condition called retrograde ejaculation. And usually in childbearing men, you generally recommend that they bank sperm before these procedures, particularly at L5S1, because there is a risk that could cause sterility over time. The major downside of an A-lift is made up for by the T-lift, and that's that you don't get direct decompression of the nerve itself. So in a T-lift, you go in from the back, you shave out around the nerves, you approach the disc space from an angle from the back, and basically put the interbody cage in that way. A lot of times with the T-lift, you do use screws and rods to kind of anchor that into place. Major advantage of a T-lift, one of the reasons I like doing a T-lift is because it gives you direct decompression of the nerve, meaning that when you're done, you see the nerve completely decompressed. Downside of a T-lift is because you're working on a smaller channel, there's less room to put in a larger cage. Now, we've overcome that a lot of times now with expandable cages, which allow us to go in and expand the height of the cage back to normal. The third technique, the lateral interbody fusion, is one where you go in from the side. Major advantage of that, the surgeon can do it directly without an access surgeon in many cases. The other advantage is because when the patient is laying on their side, the abdominal contents move to the side, it tends to be maybe a little more traumatic, a little bit less risk of injury to major vascular structures and to the bowel as you would with an A-lift. A major disadvantage of that, again, you don't get that direct decompression, particularly in the lower lumbar spine. The lumbar sacral plexus tends to be very prominent at L5S1, so there's a very high risk of nerve injury. In fact, most people would say it's contraindicated to do a lateral interbody fusion at the L5S1 level because of the risk of injury to the lumbar sacral plexus. Additionally, the hip can block the access sometimes, particularly lower down, which can create problems in terms of exposure. Finally, particularly at 4.5 and 5.1, I find that the retraction of the